You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
Anxiety disorders. 20 board-style questions with clinical examples. Question 1. The worrier who can't stop. A 42-year-old accountant presents saying, "I worry about everything. My job, my kids, my health, money, even whether I lock the front door." She reports this has been going on for at least 2 years. She has muscle tension in her shoulders, difficulty sleeping, irritability with her husband, and trouble concentrating at work. She says, "I know my worrying is excessive, but I just can't turn it off." GAD-7 score is 16. What is the most likely diagnosis? A. Panic disorder. B. Social anxiety disorder. C. Generalized anxiety disorder. D. Obsessive compulsive disorder. Answer C. Generalized anxiety disorder. GAD. GAD is defined by excessive, uncontrollable worry about multiple domains: work, health, family, finances, occurring more days than not for at least 6 months. This patient has been worrying for 2 years across multiple life areas. That's the hallmark. She also meets the symptom threshold, greater than or equal to 3 of the 6 associated symptoms: muscle tension, sleep disturbance, irritability, difficulty concentrating. The key differentiator from other anxiety disorders is that GAD worry is diffuse. It spans many topics and isn't limited to one specific trigger. OCD involves intrusive, unwanted thoughts, obsessions with repetitive behaviors, compulsions. Checking the door once is normal worry, not OCD. Panic disorder involves recurrent, unexpected panic attacks, which she doesn't describe. Social anxiety disorder is specific to social/performance situations. First-line treatment is SSRIs or SNRIs. Escitalopram, sertraline, duloxetine, venlafaxine all have strong evidence, and/OR CBT. Buspirone is a second-line option specifically for GAD. Question 2. The sudden storm. A 28-year-old teacher is brought to the ED by her husband. She describes an episode that started 20 minutes ago while watching TV. Sudden overwhelming fear, heart pounding, chest tightness, shortness of breath, tingling in her hands, dizziness, and a feeling she was going to die. The episode peaked within about 5 minutes and is now subsiding. She says, "This has happened 4 times in the past month, always out of nowhere." She now avoids going to the grocery store alone because she's terrified it will happen in public. ECG, troponin, and D-dimer are normal. What is the diagnosis? A. Generalized anxiety disorder. B. Panic disorder. C. Acute coronary syndrome. D. Specific phobia. Answer B. Panic disorder. This is a textbook panic disorder presentation. The DSM-5 requires recurrent, unexpected panic attacks. Abrupt surge of intense fear peaking within minutes, with greater than or equal to 4 physical/cognitive symptoms, plus at least 1 month of persistent concern about additional attacks or significant maladaptive behavioral change. She has had 4 unexpected attacks in 1 month, recurrent. They occur out of nowhere, unexpected, no obvious trigger. Each includes greater than or equal to 4 symptoms: palpitations, chest tightness, dyspnea, paresthesias, dizziness, fear of dying. And she has changed her behavior, avoids grocery store alone. The cardiac workup is negative, ruling out ACS. This is not GAD. GAD is chronic diffuse worry, not episodic surges of terror. This is not agoraphobia yet. She avoids one situation, but agoraphobia requires fear in greater than or equal to 2 of 5 specific situation types. However, agoraphobia frequently co-occurs with panic disorder. First-line treatment, SSR, is sertraline escitalopram, or SNR is venlafaxine XR. CBT with interoceptive exposure, deliberately inducing panic-like sensations in a safe setting, is highly effective. Question 3. The spotlight fear. A 19-year-old college freshman presents because she has been skipping classes. She says, "I'm terrified the professor will call on me. Everyone will stare at me and see me turn red and shake. They'll think I'm stupid." She avoids eating in the dining hall, won't attend parties, and has dropped a class that required a group presentation. She has had these fears since middle school, but says, "College is so much worse because I don't know anyone." She denies panic attacks that come out of nowhere. Her anxiety is always triggered by social situations. What is the diagnosis and what is the first-line treatment? A. GAD. Start buspirone. B. Social anxiety disorder. Start SSRI and / or CBTC. Panic disorder with agoraphobia. Start benzodiazepine D. Avoidant personality disorder. Refer for long-term psychodynamic therapy. Answer B. Social anxiety disorder. Start SSRI and / or CBT. Social anxiety disorder, SAD, is characterized by marked fear of social situations where the individual is exposed to possible scrutiny by others, with concerns about embarrassment, humiliation, or negative evaluation. This patient fears being called on, scrutiny, blushes and shakes, physical symptoms she finds embarrassing, and avoids social situations, dining hall, parties, presentations. This patient fears being called on, scrutiny, blushes and shakes, physical symptoms she finds embarrassing, and avoids social situations, dining hall, parties, presentations. Her symptoms have persisted since middle school, well over 6 months, and cause significant functional impairment, dropping classes, social isolation. The key differentiator from panic disorder is that her anxiety is always triggered by social situations. It's not unexpected. The key differentiator from GAD is that her worry is specific to social evaluation, not diffuse across multiple domains. First-line treatment is SSR is. Paroxetine, sertraline, escitalopram, fluvoxamine all have evidence. Or SNR is venlafaxine XR. CBT with exposure to feared social situations is equally effective. Avoidant personality disorder has significant overlap with SAD, but is a personality pattern, not an anxiety disorder. And the treatment approach is similar. Question 4. The performance-only subtype. A 35-year-old attorney has no difficulty in social situations. She enjoys dinner parties, networking events, and casual conversations. However, she becomes severely anxious when she has to argue cases in court. She experiences tremor, sweating, palpitations, and a shaky voice that she fears the jury will notice. She has started declining high-profile cases. She does not want a daily medication. What is the best treatment approach? A. Start sertraline 50 milligrams daily. B. Propranolol 10 to 20 milligrams. PRN 30 to 60 minutes before court appearances. And / or CBTC alprazolam 0.5 milligrams PRN before court. D. Start venlafaxine XR 37.5 milligrams daily. Answer B. Propranolol 10 to 20 milligrams PRN 30 to 60 minutes before court appearances. And / or CBT. This is the performance-only subtype of social anxiety disorder. Fear is restricted to speaking or performing publicly, with no generalized social anxiety. For this subtype, daily SSR is / SNR is often unnecessary and more burdensome than the condition warrants. Beta blockers, propranolol 10 to 40 milligrams, taken PRN 30 to 60 minutes before the performance situation reduce the autonomic symptoms. Tremor, sweating, tachycardia, shaky voice, that are the primary concern. The JAMA review notes that although clinical trial evidence for beta blockers in anxiety is limited, they are commonly used for performance anxiety and may reduce symptoms when taken as needed. A trial dose should be tested before the actual performance situation to check for side effects: hypotension, bradycardia, fatigue. CBT with exposure, practicing courtroom scenarios in graduated steps, is also highly effective. Benzodiazepines are an alternative PRN option but may cause sedation, not ideal for an attorney who needs to be sharp in court. The patient specifically doesn't want a daily medication, making PRN propranolol the best match. Question 5. The medication selection puzzle. APMHNP is choosing medications for 3 patients with different anxiety disorders. Match the best medication to each patient. Patient A, 50-year-old with GAD and comorbid diabetic neuropathy pain, wants 1 medication for both problems. Patient B, 32-year-old with GAD who previously failed sertraline and escitalopram, does not want a controlled substance. Currently on no medications. Patient C, 25-year-old with panic disorder having 3 to 4 attacks per week. Just started escitalopram 5 mg today. Needs rapid symptom control while waiting for the SSRI to take effect. Answers: Patient A, duloxetine. Duloxetine is an SNRI with FDA approval for both GAD and diabetic peripheral neuropathy. 1 medication addresses both conditions. It also has approval for fibromyalgia and chronic musculoskeletal pain. Patient B arrow, buspirone. Buspirone is a 5-HT1A partial agonist that is FDA approved specifically for GAD, not other anxiety disorders. It is not a controlled substance, has no dependence potential, no sedation, and no sexual dysfunction. It is a reasonable second-line option after SSRI/SNRI failure. The downside, it takes 2 to 4 weeks to work and is only effective for GAD. It does not work for panic disorder or social anxiety disorder. Patient C, short-term benzodiazepine, e.g. clonazepam 0.25 to 0.5 mg BID. Benzodiazepines provide rapid anxiolytic effects within the first week. They are the fastest-acting anti-anxiety medications. The Lancet review recommends that benzodiazepines should be given cautiously, never as monotherapy and limited to the first few weeks until the SSRI becomes effective, 2 to 4 weeks. They should be prescribed at a fixed dose schedule, not PRN for panic disorder, then tapered once the SSRI is working. Standing dosing prevents the reinforcement of avoidance behavior that PRN dosing can create. Question 6. The GAD-7 interpretation. A patient completes a GAD-7 screening questionnaire with the following responses, all rated nearly every day, equals 3 points each. Feeling nervous/anxious, can't stop worrying, worrying too much, trouble relaxing, restless, easily annoyed, feeling afraid. Total score, 21. What does this score indicate and what is the next step? A. Minimal anxiety. Reassure and follow up in 3 months. B. Mild anxiety. Recommend lifestyle modifications, only C. Severe anxiety. Initiate pharmacotherapy and / or CBT. Assess for comorbid depression and suicidality. D. The GAD-7 is not validated for clinical use checkmark. Answer C. Severe anxiety. Initiate pharmacotherapy and / or CBT. Assess for comorbid depression and suicidality. The GAD-7 scoring is 0 to 4 equals minimal, 5 to 9 equals mild, 10 to 14 equals moderate, 15 to 21 equals severe. A score of 21 is the maximum and indicates severe anxiety requiring active treatment. A score of greater than or equal to 10 has 89% sensitivity and 82% specificity for GAD. However, the GAD-7 is a screening tool, not a diagnostic tool. A high score should prompt a clinical interview to confirm the diagnosis and determine the specific anxiety disorder, GAD, panic, social anxiety, etc. Critical next steps include assess for comorbid depression, Anxiety and depression co-occur in up to 60% of cases. Administer PHQ-9. Assess for suicidality. Rule out medical causes, hypothyroidism, pheochromocytoma, cardiac arrhythmias, substance use, and initiate treatment. For severe anxiety, pharmacotherapy, SSRI/SNRI, plus psychotherapy, CBT, is recommended over either alone. Question 7. The medical mimic. A 45-year-old woman presents with episodes of palpitations, sweating, tremor, and intense anxiety occurring several times per week. She also reports unintentional weight loss of 15 pounds, heat intolerance, and diarrhea. On exam, her heart rate is 110, she has a fine tremor, and her thyroid is diffusely enlarged. Before diagnosing an anxiety disorder, what must the PMHNP do? A. Start sertraline immediately. The symptoms are clearly anxiety. B. Order thyroid function tests. This presentation suggests hyperthyroidism. C. Start propranolol for the palpitations and tremor. T. Refer for CBT. Answer B. Order thyroid function tests. This presentation suggests hyperthyroidism. This is a critical board concept. Always rule out medical causes before diagnosing an anxiety disorder. The DSM-5 specifically requires that the disturbance is not attributable to the physiological effects of a substance or another medical condition. This patient has classic hyperthyroidism signs: weight loss, heat intolerance, tachycardia, tremor, diarrhea, and goiter that can perfectly mimic anxiety. Other medical conditions that mimic anxiety include pheochromocytoma, episodic hypertension, sweating, palpitations, cardiac arrhythmias, SVT, atrial fibrillation, hypoglycemia, pulmonary embolism, COPD, and medication/substance effects. Caffeine, stimulants, corticosteroids, thyroid hormone, decongestants, withdrawal from alcohol/benzodiazepines/opioids. The PMHNP should order TSH and free T4. If hyperthyroidism is confirmed, treating the thyroid condition will resolve the anxiety symptoms. Propranolol might actually be appropriate here, but for hyperthyroidism symptom management, not as an anxiolytic. Question 8. The benzodiazepine dilemma. A 55-year-old man with GAD has been on alprazolam 1 mg TID for 8 years, prescribed by his previous provider. He wants to continue it because it's the only thing that works. He also has a history of alcohol use disorder, in remission for 3 years, and mild COPD. His current GAD-7 score is 12 despite the alprazolam. What should the PMHNP do? A. Continue alprazolam. It's been working for 8 years. B. Increase alprazolam to 1.5 mg TID for better symptom control. C. Develop a plan to gradually taper alprazolam while initiating an SSRI/SNRI and CBTD. Abruptly discontinue alprazolam and start buspirone. Answer C. Develop a plan to gradually taper alprazolam while initiating an SSRI/SNRI and CBT. This patient has multiple red flags for continued benzodiazepine use: history of alcohol use disorder, cross-tolerance and addiction risk, COPD, benzodiazepines can cause respiratory depression, long-term use, 8 years, dependence is virtually certain, and still symptomatic. GAD-7 of 12 despite the medication, suggesting tolerance has developed. Benzodiazepines are not recommended as long-term monotherapy for anxiety disorders. The Lancet review states that benzodiazepines only act acutely, lead to relapse after discontinuation, and are associated with dependency, requiring strict monitoring. The correct approach is to start an SSRI or SNRI first, allow 4 to 6 weeks to reach therapeutic effect, initiate CBT simultaneously, and then begin a very gradual benzodiazepine taper, reduced by no more than 10 to 25% every 2 to 4 weeks. Never abruptly discontinue benzodiazepines after long-term use. Benzodiazepines after long-term use. This can cause life-threatening withdrawal seizures. The taper for an 8-year user may take 6 to 12 months or longer. Question 9. The specific phobia. A 30-year-old woman has an intense fear of needles. She avoids all blood draws, vaccinations, and dental procedures. She recently declined a recommended surgery because it would require an IV. She knows her fear is irrational, but says, "I just can't do it. I feel like I'm going to faint." She reports that her father and sister also faint around needles. What is the diagnosis, and what is the first-line treatment? A. Panic disorder, start SSRIB. Specific phobia, blood injection injury type. Exposure therapy with applied tension technique. C. GAD, start SNRID. Somatic symptom disorder, start CBT. Answer B. Specific phobia, blood injection injury type, exposure therapy with applied tension technique. Specific phobia is characterized by marked excessive fear of a specific object or situation that is out of proportion to the actual danger, almost always provokes an immediate anxiety response, and is actively avoided or endured with intense distress. The blood injection injury BII subtype is unique among all anxiety disorders because it involves a vasovagal response. The initial sympathetic surge, tachycardia, hypertension, is followed by a parasympathetic rebound, bradycardia, hypertension, syncope. This is why patients with BII phobia actually faint, unlike other phobias where patients feel like they might faint but don't. The family history, father and sister, is typical. BII phobia has the strongest genetic/familial component of all specific phobias. First-line treatment is exposure therapy, but with a special modification called the applied tension technique. The patient learns to tense large muscle groups, arms, legs, torso, during exposure to counteract the vasovagal drop in blood pressure. Medications are generally not first line for specific phobias. Exposure therapy is far more effective. Question 10. The SSRI startup jitters. A PMHNP starts a 24-year-old woman with panic disorder on sertraline 50 milligrams per day. After 3 days, the patient calls in distress. "This medication is making me worse. My heart is racing, I feel jittery, and I had 2 panic attacks yesterday. I want to stop it." How should the PMHNP respond? A. Discontinue sertraline. It's clearly not working. B. Switch to a benzodiazepine. SSR is don't work for panic disorder. C. Reassure the patient, reduce the dose to 25 milligrams, and explain that initial activation is common and temporary. D. Add aripiprazole for augmentation. Answer C. Reassure the patient, reduce the dose to 25 milligrams, and explain that initial activation is common and temporary. This is the classic SSRI activation syndrome, or jitteriness syndrome, a well-known phenomenon where anxiety symptoms temporarily worsen during the first 1 to 2 weeks of SSRI treatment before improving. The JAMA review specifically notes that patients with anxiety disorders tend to be sensitive to adverse effects, which commonly occur before therapeutic effects are appreciated, and that some adverse effects can replicate anxiety symptoms. Jitteriness, palpitations. This is why anxiety disorder guidelines recommend starting antidepressants at lower doses than those used for depression. Start low, go slow. For panic disorder, sertraline should be started at 25 milligrams, not 50 milligrams. The correct response is to reduce the dose to 25 milligrams, reassure the patient that this is a known temporary effect, and explain that the therapeutic anxiolytic effect takes 2 to 4 weeks to begin. A short-term benzodiazepine bridge, for example, clonazepam 0.25 milligrams BID for 2 to 3 weeks, can be offered to manage symptoms during the SSRI titration period. Never abandon the SSRI trial based on the first few days. Question 11. The comorbidity challenge. A 38-year-old man presents with GAD 7 equals 15, and comorbid major depressive disorder, PHQ-9 equals 18. He has been struggling with both conditions for over a year. He asks, do I need 2 different medications, one for anxiety and one for depression? What is the best pharmacotherapy approach? A. Yes, start sertraline for depression and buspirone for anxiety. B. No. A single SSRI or SNRI treats both conditions simultaneously. C. Start bupropion. It treats both depression and anxiety. D. Start a benzodiazepine for anxiety and an SSRI for depression. Answer B. A single SSRI or SNRI treats both conditions simultaneously. Anxiety and depression co-occur in up to 60% of cases, and this is one of the most common clinical scenarios in psychiatric practice. The good news is that SSRIs and SNRIs are first-line treatments for both conditions. A single medication addresses both. Escitalopram, sertraline, venlafaxine, XR, and duloxetine all have strong evidence for both GAD and MDD. There is no need for two separate medications. Bupropion is wrong here. It can worsen anxiety. It's activating. Bupropion is wrong here. It can worsen anxiety. It's activating with norepinephrine dopamine reuptake inhibition. Buspirone is only effective for GAD, not depression, and adding it to an SSRI adds complexity without clear benefit. A benzodiazepine might be used short-term for acute anxiety but should not be the primary anxiety treatment. The Lancet review notes that comorbid depression is one factor that might prioritize pharmacotherapy over psychotherapy alone. Combined SSRI/SNRI plus CBT is the optimal approach for this severity level. Question 12. The panic attack versus panic disorder distinction. 3 patients present to the PMHNP reporting panic attacks. Which patient meets criteria for panic disorder? Patient A had 1 panic attack during a car accident 2 weeks ago. No further attacks. No worry about future attacks. Patient B has panic attacks only when she sees a spider. She avoids basements and garages. No attacks in other situations. Patient C has had 6 unexpected panic attacks over 3 months. She constantly worries about having another one, has started avoiding exercise, afraid it will trigger an attack, and checks her pulse multiple times daily. Answer: Patient C meets criteria for panic disorder. Patient A had a single panic attack in response to a traumatic event. Panic attacks can occur in the context of any disorder or even in healthy people during extreme stress. A single attack without persistent concern or behavioral change does not meet criteria for panic disorder. Patient B has panic attacks that are expected. They occur only in response to a specific phobic stimulus, spiders. This is specific phobia with panic attacks, not panic disorder. The DSM-5 specifies that panic disorder requires unexpected attacks. Patient C has recurrent unexpected attacks, 6 over 3 months, persistent concern about future attacks, constant worry, and significant maladaptive behavioral change, avoids exercise, checks pulse, meeting all 3 DSM-5 criteria for panic disorder. The key teaching point: panic attacks are a symptom that can occur across many disorders. Panic disorder is a specific diagnosis requiring unexpected attacks plus persistent worry or behavioral change for greater than or equal to 1 month. Question 13. The treatment duration. Question: a 40-year-old woman with social anxiety disorder has been on escitalopram 20 milligrams per day for 10 months. She is doing well. GAD-7 is 4. She's attending social events, and she recently gave a presentation at work. She asks, "Can I stop my medication now?" How should the PMHNP advise her? A. Yes, she's been on it long enough and is in remission. B. Continue for at least 12 months total, then consider a very gradual taper with close monitoring. C. She needs to stay on medication for life. D. Switch to buspirone for maintenance. Answer B. Continue for at least 12 months total, then consider a very gradual taper with close monitoring. The JAMA review states that for patients who respond to medication, the drug should be continued for at least 1 year to reduce relapse. Discontinuing antidepressants before 1 year leads to symptom relapse in up to 50% of patients. This patient has been on escitalopram for 10 months. She should continue for at least 2 more months to complete the minimum 12-month course. When discontinuation is attempted, it should be gradual, 1 dosage step per month, with close monitoring to distinguish between withdrawal symptoms and disorder relapse. If relapse occurs during or after taper, well-tolerated pharmacotherapy may be maintained indefinitely. Buspirone is not effective for social anxiety disorder. It only has evidence for GAD. The decision to taper should also consider the patient's history. If she has had multiple relapses, chronic symptoms, or severe impairment, longer-term or indefinite treatment may be warranted. Question 14. The interoceptive exposure concept. APMHNP is explaining CBT for panic disorder to a patient. The patient asks, "What is interoceptive exposure, and why would I deliberately make myself feel panicky?" How should the PMHNP explain this? A. We'll have you avoid all situations that trigger panic. B. We'll deliberately induce panic-like physical sensations in a safe setting so your brain learns they are not dangerous. C. We'll use deep breathing to prevent panic attacks from ever happening. D. We'll use hypnosis to eliminate your fear response. Answer B. We'll deliberately induce panic-like physical sensations in a safe setting so your brain learns they are not dangerous. Interoceptive exposure is a core component of CBT for panic disorder. It involves systematically exposing the patient to the physical sensations they fear, palpitations, dizziness, shortness of breath, tingling, through safe exercises such as breathing through a straw, dyspnea, spinning in a chair, dizziness, running in place, tachycardia, or hyperventilating, tingling, lightheadedness. The JAMA Review explains that exposure-based interventions systematically help patients approach currently avoided situations and or sensations associated with anxiety. The rationale is that panic disorder is maintained by catastrophic misinterpretation of normal bodily sensations. The patient feels their heart race and thinks, "I'm having a heart attack." By repeatedly experiencing these sensations in a safe environment without the feared catastrophe occurring, the brain learns that the sensations are harmless. Exposure strategies may initially increase anxiety but are ultimately more effective than cognitive strategies alone. Meta-analyses show large effect sizes for exposure, Hedges G equals 0.78, versus small to medium for cognitive strategies alone, Hedges G equals 0.38. Question 15. The elderly patient trap. A 72-year-old woman with GAD and mild cognitive impairment is referred to the PMHNP. She has been on lorazepam 1 mg TID for 5 years, prescribed by her PCP. Her daughter reports that the patient has had 2 falls in the past month and seems more confused than usual. What is the PMHNP's priority concern? A. The lorazepam is causing cognitive impairment and fall risk. Plan to taper and switch to an SSRIB. The falls are unrelated to the lorazepam. Continue current regimen. C. Increase lorazepam. Her anxiety must be undertreated. D. Add donepezil for the cognitive impairment while continuing lorazepam. Answer A. The lorazepam is causing cognitive impairment and fall risk. Plan to taper and switch to an SSRI. Benzodiazepines in elderly patients are a high-risk combination. They increase fall risk, sedation, impaired coordination, muscle relaxation, worsen cognitive impairment, can mimic or accelerate dementia, and are listed on the Beers criteria as potentially inappropriate medications for older adults. This patient's falls and worsening confusion are likely caused or worsened by the lorazepam. The PMHNP should develop a slow taper plan, reduced by 10 to 25% every 2 to 4 weeks. Elderly patients need even slower tapers, while initiating an SSRI, sertraline or escitalopram are preferred in elderly due to fewer drug interactions. CBT is also effective in older adults. The Lancet review specifically warns that comorbid somatic disorders and polypharmacy call for cautious treatment initiation and careful evaluation of drug interactions in patients aged greater than or equal to 65 years. Adding donepezil while continuing the offending medication would be treating the side effect rather than removing the cause. Question 16. The substance-induced anxiety trap. A 25-year-old graduate student presents with severe anxiety, insomnia, tremor, and palpitations that started 2 days ago. He reports drinking 6 to 8 cups of coffee daily using his prescribed Adderall, amphetamine, 30 milligrams BID for ADHD, and recently starting an albuterol inhaler for new-onset asthma. He also admits to drinking a few beers every night, but says he hasn't had alcohol in 3 days because he's been studying for exams. Before diagnosing an anxiety disorder, what must the PMHNP consider? A. This is clearly GAD. Start an SSRIB. Multiple substance-related causes must be ruled out. Caffeine excess, stimulant effects, beta agonist effects, and possible alcohol withdrawal. C. This is panic disorder. Start a benzodiazepine D. This is social anxiety about exams. Start propranolol. Answer B. Multiple substance-related causes must be ruled out. Caffeine excess, stimulant effects, beta agonist effects, and possible alcohol withdrawal. This patient has 4 potential substance-related causes of anxiety, and the DSM-5 requires ruling out substance/medication-induced anxiety before diagnosing a primary anxiety disorder. Excessive caffeine, 6 to 8 cups per day equals 600 to 800 milligrams, well above the 400 milligram threshold associated with anxiety symptoms, causes jitteriness, palpitations, insomnia, and tremor. Amphetamine, Adderall, is a stimulant that directly increases norepinephrine and dopamine, causing anxiety, tachycardia, and insomnia. Albuterol is a beta-2 agonist that can cause tremor, tachycardia, and anxiety. Most critically, he stopped alcohol 3 days ago after regular nightly use. Alcohol withdrawal typically begins 6 to 24 hours after the last drink and peaks at 24 to 72 hours, causing anxiety, tremor, insomnia, tachycardia, and potentially seizures. The PMHNP should assess for alcohol withdrawal, CIWA protocol, reduce caffeine, review the Adderall dose and timing, and reassess anxiety after addressing all substance-related factors. Question 17. The CBT refusal. A 33-year-old man with social anxiety disorder has been on paroxetine 40 milligrams per day for 12 weeks with partial response. Still avoids most social situations. GAD-7 improved from 18 to 12. The PMHNP recommends CBT, but the patient says, "I don't believe in therapy. I just want a medication that works better." What is the best next step? What is the best next step? A. Respect his wishes and increase paroxetine to 60 milligrams. B. Switch to venlafaxine XRC. Augment with a benzodiazepine D. Consider switching to a different SSRI or augmenting, while continuing to discuss the benefits of CBT. Answer D. Consider switching to a different SSRI or augmenting, while continuing to discuss the benefits of CBT. This patient has a partial response to paroxetine at an adequate dose, 40 milligrams, after an adequate trial, 12 weeks. The JAMA review recommends that if anxiety symptoms do not improve after 4 weeks, the likelihood of medication response diminishes, and for refractory anxiety, decisions to switch to another antidepressant or add CBT should depend on whether partial response is present and which symptoms remain. Options include optimizing the dose. Paroxetine can go to 60 milligrams, switching to a different SSRI or SNRI. Venlafaxine XR has strong evidence for SAD. Or augmenting. Pregabalin has evidence for SAD, though it's not FDA approved in the US for anxiety. While respecting patient autonomy, the PMHNP should continue to educate about CBT's effectiveness. Meta-analyses show CBT has medium to large effect sizes for SAD, and the benefits persist after treatment ends, unlike medication, where relapse is common after discontinuation. The patient may become more open to CBT over time, especially if medication alone proves insufficient. Question 18. The pregnancy dilemma. A 30-year-old woman with well-controlled panic disorder on sertraline 100 milligrams per day discovers she's 8 weeks pregnant. She's terrified about taking medication during pregnancy and wants to stop sertraline immediately. How should the PMHNP counsel her, A. Stop sertraline immediately. All SSRIs are contraindicated in pregnancy. B. Discuss the risks and benefits. Untreated panic disorder carries risks to both mother and fetus. Sertraline is considered relatively safer in pregnancy, and abrupt discontinuation can cause relapse and discontinuation syndrome. C. Switch to a benzodiazepine. They are safer in pregnancy than SSR is. D. Switch to buspirone. It has no pregnancy risks. Answer B. Discuss the risks and benefits. Untreated panic disorder carries risks to both mother and fetus. Sertraline is considered relatively safer in pregnancy, and abrupt discontinuation can cause relapse and discontinuation syndrome.
Thanks for watching. Like and subscribe for more content.